Thanks for having me. This has been great so far. I'm at Mass General. We have a program called the LEAP program. It's a Lower Extremity Evaluation and Preservation Program. And I'm going to get into why this is so important today. We're going to look at the diabetic foot ulcer in diabetic foot management, and especially how it applies to PAD. We're going to try to recognize early warning signs and initial management for the diabetic foot. And also we'll go into multidisciplinary care, because there's study after study showing that multidisciplinary care is what gets these patients better. Just my disclosure, nothing relevant to this talk. So 1/3 of all diabetes-related costs in the US is to the diabetic foot. So there's a huge amount of costs in our system. It's burdening our system greatly. 34 million people in the United States with diabetes. Of those people with diabetes, 1/4 of them, 25%, are going to get a foot ulcer. Half of them will get infected, and 20% of those are going to get some level of amputation. And so the numbers are just huge, even though they're smaller and smaller. The numbers are huge of the people getting amputations right now. The biggest thing is after they get one foot ulcer, there's a 60% chance of them getting another foot ulcer at some point in their life. So this isn't somebody, it's not like a fracture where we heal it and they go away, they don't come back. These people keep on coming back over and over and over again. That's why I'm so busy. And then the biggest thing is our amputation rate. It's too high. Most of these are unnecessary. 150,000 amputations in the US annually. We need to do better. And why is limb salvage is kind of like what we call any management of the diabetic foot so important? It's because these people don't do well after. So this is comparing diabetic foot ulcer, Charcot foot, critical limb ischemia to cancer, because cancer, there's a lot of attention to cancer. So if someone has a diabetic foot ulcer, their chance of dying in 5 years, so this is 5-year mortality rate, is significantly higher than breast cancer and almost equal to all cancers combined. Now that jumps up after they get an amputation, a major amputation, so above or below knee amputation. That jumps up to sometimes, the varying studies, between 60 and 80% 5-year mortality. So after they get an amputation from a diabetes-related cause, their chance of dying is extremely high. And then similar to that is critical limb ischemia or chronic limb ischemia. So our goals of limb salvage is basically to prevent the amputation, which leads to their premature death. But we also want to preserve function. And so their feet don't have to look cute after all of this. A toe amputation is considered limb salvage, where they can walk, they can use their foot, they can wear a shoe. This foot doesn't look super cute, but this patient was walking around in a diabetic shoe and they were functioning and they were living their life. We want to increase hospital-free, ulcer-free days, so basically optimize their quality of life. And a plantar grade foot, in other words, a lot of times they end up with these deformities where they have bones sticking out the bottom of their foot, developing ulcers and recurrent problems. We want to minimize that. And what's happening now, the incidence of diabetic foot ulcers is actually increasing. So even though before people with diabetes used to die of a heart attack, right? Now the cardiologists are doing a great job at keeping them alive. They're getting their diabetic medications, their GLP-1s, their diabetes is better controlled. They're living longer. So now there's more diabetics out there. And they may be skinny, but they still get old. And older people have a hard time healing. So this is usually how diabetic foot ulcer happens. They start out with a callus. They get kind of a bruise underneath the callus, where it's actually a wound. This is where we want to catch them. What is this? So we want to catch them before they get here. So ideally, if you catch that callus before it turns into this is actually a wound here, and you want to prevent it from getting there. So if you intervene here, they don't get that wound to begin with. Usually this is a neuropathic patient. If they have PVD, it just gets worse and worse. And PVD is an independent predictor of poor outcomes. Now, when should these patients see a specialist? So usually, for me, any patient with a diabetic foot ulcer should go to a podiatrist if you can. The reason we need to get these healed and get these healed soon is if they don't heal or decrease in surface area by 50% in the first 4 weeks, are very, very unlikely to heal in 3 months. So early aggressive treatment, either they're gonna heal really quickly or they're not. And then those patients that are not, the wounds haven't decreased in size by 50% at that 4-week mark, they really need to get more evaluation and a higher level of care here. So luckily you guys ate lunch already. So let's get into PVD a little bit more. Below the knee, you have bad disease, or the big artery disease, where it's the popliteals, the femorals, and also the small artery disease. And why this is important is because we actually do treat them in different ways. Before, the small artery disease was kind of this realm where we couldn't do much, and now there's being more and more done in terms of technology of what can be done for the small artery disease. We did save this patient's foot, if you're wondering. So the bad disease is the patients that they're a candidate usually, a lot of times, for revascularization. So they have a blockage, they can do something to get around there, and there's flow to the foot. These patients, if I need to do an amputation on their toe, I can do it immediately after because they get blood flow like pretty much immediately after any revascularization procedure. Now, the small artery disease, this is more of a challenge because traditionally I used to send my patients and I'd send them to vascular because their foot looks ischemic. I know their foot is ischemic, and there was nothing that could be done. They'd send them back to me. They'd get a toe amputation. And then the toe amputation wouldn't heal. They go on to a transmetatarsal amputation and below knee amputation. Now we have a little more advances, which I'll get into in a little bit, including deep venous arterialization, that's actually saving these people and offering more options, still new in research. So this is kind of like a little chart, the sad and bad disease. The microvascular disease, the small artery disease, is a little bit different pathophysiology in that the basement membrane is thickened as opposed to just that plaque. Some difference in symptoms. So traditionally we think people with peripheral artery disease get claudication. Now, if they just have the small artery disease, there's no blood going to the toes, they might not get the claudication, but their foot is still ischemic. So they might not get the calf pain because there's flow going to the calf, but their wound doesn't heal. And it's that microperfusion to the wound that is the problem. ABIs we usually get. The thing is, most of these patients have calcified arteries, and so ABIs are usually not diagnostic. We're more so going towards toe pressures, especially with patients suspected of small artery disease. So if they have a toe pressure under 65, we know that's they probably won't heal a wound and something needs to be done. Treatment options, there's newer things. Again, for the small artery disease, traditionally there is not much options. Now we have more like topical oxygen therapy and deep venous arterialization versus more the traditional revascularization approaches were working better for the larger artery disease. Usually diabetics have both, and so they need to be screened appropriately. Again, toe pressures are kind of more what we're going for. Usually, so I'm a podiatrist. Usually I order ABIs and x-rays for all my patients. What I'm looking for in ABI, if I need to send them over to vascular, is if one, their ABI is low, and so they have PAD on the ABI. 2, the toe pressure. So if the toe pressure is under 65 and they have a wound, they need to get over to vascular. And then the flat waveforms. This patient definitely needs to get to vascular. It's kind of flatlining in the foot. Another thing we're using more now is x-rays, not only to look at osteomyelitis, concern for infection, but also the MAC score, so the medial artery calcification. What this scoring system is basically if you can see the arteries in the foot, that patient likely will not do well. They have a higher incidence of below and above knee amputation and poorer outcomes after revascularization. So if you get a plain x-ray and you can see all these arteries, then they probably really need to have aggressive vascular treatment. And what we want to prevent is to prevent these patients from going on to CLTI. It used to be called critical limb ischemia. Now there's a push towards like chronic limb ischemia because the reality is this has been going on for a while and it's just kind of the buildup that's gotten them to this point. But if the patient is at the point of CLTI, as defined as PAD with rest pain, gangrene, or a lower extremity ulcer that's non-healing, they need to, this is an urgent referral to vascular. Okay, if they have a necrotic toe and they have PAD, they need to get there ASAP because time is tissue. These patients have a very high morbidity and mortality rate, so early aggressive treatment is important. Now, what do we do? How do we treat these patients if they have mild PAD? Supervised exercise therapy, usually covered by insurance if you can get them to a center that actually does it, and there has to be an accreditation for it. It's considered first-line therapy for mild to moderate PAD. Now, this does not work in CLTI. It does not work when they have rest pain, but it does work for after a revascularization to keep it going. So basically, you just want them to walk as much as possible, which everyone else was saying all day today. Specifically, these programs have been shown to be better than home programs. So what they do is they get them on a treadmill and they walk until they have symptoms. And once they have symptoms, they experience those symptoms, they take a break, and then they get them back on once the claudication pain has dissipated, and then keep on going, 30 to 60-minute sessions, 3 times a week for a minimum of 12 weeks. The problem is insurance will only cover it for usually 3 months. And so what do? I tell all my patients to walk as much as possible. And then I'm not a vascular surgeon, but I work very closely with my vascular colleagues because we share all the patients. I do the wound care for all the patients that need to go to them for their revasc. You know, traditional bypass is kind of like going around a road. And then there's different drug-coated balloons and things like that, and deep venous arterialization. This is one of the newer things on the scene. This is where you connect an artery to a vein, and this is indicated for critical limb ischemia with patients that have no option. And then the blood flows through the venous system into the foot. The big thing to know for this is the wound care is very different after. So traditionally, when someone gets a bypass, if we need to do a toe amputation, we do it within a week after. Deep venous arterialization takes about 3 months to actually work and form capillaries to fill and to get to the wound. And so any level of amputation needs to be delayed if possible, usually up to 3 months. Other things that we're doing. Hyperbarics. Hyperbarics is awesome. It has some really good studies. It's not going to replace a revascularization. So, you know, if you need to get across the country, and you need a plane, the revascularization, the bypass is a plane to get across there. The hyperbarics is like a bicycle. And so it'd be good if you need to get to the next county. So if you have a small wound, something that needs a little extra oxygen to it because it's not getting enough oxygenation to the wound, hyperbarics works well. The big issue with hyperbarics is you need to do it usually about 2 hours a day, 5 days a week, and they're in this chamber, so it's called a dive, and it takes about 30 minutes to decompress. So I just kind of remember one of my patients telling me that he threw up when he was in the hyperbaric chamber, and he had to sit there for 30 minutes until it decompressed to get him out. So sometimes it's not ideal. And it's also, I mean, access to it. There's not a lot of facilities that have it. Even I'm in Boston where we have 1 million medical facilities. We have one, but usually there's about 6-week waiting list to get them in. So access to it is pretty tricky. Now what's newer is home topical oxygen therapy. There's some smaller studies, really good but small studies out there. So the VA is approving it and some other state insurances are approving it. And basically similar idea, similar results thus far in the studies, and it's a device that they get to their home. And so this is something that actually could be used in rural areas where it's just delivered to their house. And it's a little machine, and it hooks up to this boot, and they have these disposable boots, and it has kind of the same idea of delivering topical oxygen to the wound. The other thing that we use a lot of is skin substitutes. So this is the one on the left is from an umbilical cord of a C-section, and then the one on the right is from the placenta. And so these I use a lot in my practice. The big issue is the recurrence for the diabetic foot ulcers. So we do skin grafts. We take skin grafts from the thigh. We do full thickness, split thickness skin grafts, but you only can take so much. And these people keep on ulcerating over and over again. So there's a whole bunch out there. There's other ones from fish skin or other types of things. They're never as good as your own body, so they're never as good as a split thickness skin graft, But what we use, so for example, in this one on the left, we did an open transmetatarsal amputation, which we're doing more of to preserve the length of the foot. And so what happens is we need to get coverage over those bones. This graft will be enough to cover the bones and provide tissue over the bones, and then we can get a split thickness skin graft over it. So not necessarily replacement, but an adjunct. The one on the right, this one's from placental cells. And so those we actually can put on in the office. And so it's a wound that takes a while to heal. It promotes angiogenesis, and it kind of gives the wound a little boost to healing. The big issue with these is expense, but more insurances are covering it because the cost of these wounds not healing is extremely high. Usually they're coming into the office every week or 2 weeks for months on end. So some wound care basics, offloading is really big. Usually they have some degree of neuropathy, and so taking pressure off the wound. The big challenge is offloading them, but still telling them to walk, because sometimes you're kind of stuck between a rock and a hard place. Now, there's all these new devices, though. My goal is to have the patients walk throughout their healing of their diabetic foot ulcer. And we can do it with total contact casting. A lot of times we put felt pads on their foot. We have all sorts of different devices now that we can keep them walking. And that's the goal, because once we have them stop walking, their PAD is going to get worse. They're not going to heal. They're just going to get worse and worse and worse. And then debridements. This is, in rural medicine, you can do a lot in the office. The thing is, they really do need someone taking a blade and scraping off the slough. And so that's when they really do need to get to a wound care provider or someone that's trained in that, because a lot of times they just won't heal. They're more likely to get infected if you're not routinely doing that. So some things I do in my office, so you can offload externally through braces and boots and other things. But you can also do what's called intrinsic offloading, where you take the pressure off from the inside. So I do a lot of minimally invasive surgery, which it became hot in the podiatry world from bunions. And so people would get their bunions done with a little scar and it would look cute. Where I use it more is for these patients. So basically what I did, I went in with a little burr, broke his bone underneath that metatarsal, right underneath. Oh, I think I messed up. There we go. Right underneath where that wound was, did these 2 osteotomies. So literally broke it, put one stitch in there, had him walk on it right after, because when he walks, those bones float up and the pressure point goes away on the foot. And he did well, and that's how it's going to heal longer term. You can't expect these patients, the compliance rate with these offloading devices is less than 50% when you put them in something like a boot. And so for me, I actually have a lower threshold for the non-compliant patients to take them to surgery because they actually do better that way. Other things I do in the office is percutaneous flexor tenotomy, a wound on the tip of the toe. We go in with a little blade and snip the flexor digitorum longus tendon, usually not the brevis, and so they can still move their toe a little bit. But that DIPJ, the distal interphalangeal joint contracture, is alleviated, and so they don't get pressure on the tip of their toe, and their wound usually heals up really quickly. I've done this in a lot of patients with PAD, with scleroderma. The incision is so small that there actually has been no reported surgical site complications, as in it doesn't cause necrosis or anything like that, even in people with severe PAD. The one thing that it does cause is possible transfer lesion, and so their second toe is super straight, pressure goes away. Whenever we take pressure off of one area, it can go to another area, and so it can go to the third, fourth toe. So you guys in primary care are kind of like the arrows. Ideally, if you can get these patients to a limb salvage center, a wound care center, they're going to take care of all this, but it doesn't always work that way, as we all know. And so me and the vascular surgeon manage most of these patients, by me, like my service, podiatry and the vascular service, manage most of these patients with PAD, and then we kind of grab these other specialists. But usually they need to be at least evaluated for their circulation if they're diabetic and have a foot wound, and they need to have appropriate wound care and offloading. If you don't have a podiatrist, at least somewhere with a wound care specialist, at minimum they need to do the debridements. And so I just have another case. This was one of our joint cases. So a lot of the challenge is, this doesn't always happen on one foot, they have problems with both feet. So he presented to the hospital with a left foot infection with exposed bone. He had osteomyelitis of that metatarsal in the toe. The big issue was his right foot looked like this. He was completely walking on the side of his foot because of a history of Charcot foot, where his bones just completely collapsed. And so he had been given option, and he had a history also of infection in that right foot. So these are the patients that keep on coming back, and they get more complicated with age and time. So what did we do? We took out, first of all, he needed an angio, so he got that done first because he had so many comorbidities. And then I actually did this at the same time, so sometimes I scrub jointly with my vascular surgeon. We have two separate tables, separate surgical fields, and she did the angio while I took off the toe. Sometimes if you wait a day, it's ideal, but if you can get anesthesia and everything all in one day and prevent them from going to the OR, sometimes that works. He wasn't infected, so we needed to do it sooner rather than later. And we got this to heal up. This was his good foot, and this stayed his good foot. This was 5 years ago. He still has both of his legs. Now, this is his bad foot. The right one has continued to be a problem. So his left one, he got into a shoe, an orthotic, that's been fine since. The right one has been a problem since, and we tried all different fancy offloading devices, boots, everything else. What's worked well is we put these felt pads, literally you can get them from a craft store. I have patients get them from Amazon. Build it up because he has this big pressure point in the middle of his foot, and he has a cast, a bivalve cast where they cut it on the side so he can open it up for wound care and put it back on. And this guy literally travels every weekend. He lives his life. He never stopped walking, but he just was protected this whole time. So he's past the 5-year mark. He has both of his legs. Sometimes our goal is not necessarily to keep their legs for their whole life. We know that mortality risk, and so at least if we can keep their legs as long as possible, then sometimes that's a success. So we do all these procedures. It's like if they had cancer, you wouldn't just be like, oh, they're gonna lose their leg anyway, let's just amputate it now. A lot of these people will lose their leg at some point in life. But we do all of these to prolong their lifespan, to optimize their life for as long as possible. Because we know if they get their leg amputated, their cardiovascular disease, which they all have because this is the same disease process in the heart as it is in the legs, is just gonna get worse. So why primary care matters? This foot we did not save. Unfortunately, he had a big heel wound as well. But this guy was referred to us in this picture for bilateral below knee amputations with really bad wounds on both feet. And it shouldn't have gotten that far. There should have been intervention sooner. I mean, part of it was the patient, but these patients, when they have early warning signs, when they have claudication, when they have a toe wound, necrosis, a non-healing wound, they need to get to a wound care specialist. Optimizing all their other risk factors obviously helps. Smoking, optimizing their A1C, being on the correct antiplatelet and anticoagulation also long-term makes a huge difference. Nutritional status. Actually, about 60% of our patients are diabetic patients are found to be malnutritioned. And so they may be obese, but they're not always nutritionally optimized. A lot of times their albumin is low, especially in these sick comorbid patients. This was one of them. I mean, he had a really, really low albumin. And so really important to get nutrition involved in his healing. When you have a wound like that, your nutritional needs, when you have a large wound, your nutritional needs for protein go up significantly. So a lot of my patients, even if they're not seeing a nutritionist, if they have a large wound, they need to eat more protein. Disparities in care. So we know we're not perfect, but Black and Hispanic people have a 2 to 4 times higher amputation rate than their white counterparts. And so there are, comorbidities, and access to care does make a difference. But what studies have also found is that they have a statistically significant lower incidence of having a revascularization attempt, an angioplasty, a debridement, or a minor amputation like a toe amputation prior to proceeding to the below knee amputation. So again, we just need to do better. I think AI might have, in the future, play a role here in developing better pathways for us to follow. But we'll see. Females, so similar incidence of PAD, but they tended to present older with more with CLTI. So more people that were female had CLTI. Now, mixed on why this happens. Some of it may have to do with resistance to some antiplatelets, and that's, we have a lab at Mass General kind of like looking into that. Other things for the future, temperature and pressure monitoring. So there's all these studies for all these different devices where patients wear a pressure monitor or temperature monitor at home, and extremely accurate at predicting an ulcer may form in the near future. The biggest issue with this was actually, one, compliance, and so having these patients actually wear it, and then two, who's gonna read it? Because, I mean, in my practice, I have hundreds of patients with diabetic foot ulcers, and like, this looks like my worst nightmare of having like hundreds of alerts every day. I have enough stuff in my, my in-basket of this. So this didn't actually take off so well. There's still a lot of research being done, but where I think it may make a difference is in more rural medicine, where they're probably, a lot of these patients are okay for a year, for 6 months, but then they do get to a point where they do need to see someone sooner. And so I think it would be more useful in more of a rural area where you can get these alerts of, hey, you need to see someone now, even if you do a virtual visit and you get, something shipped out to you at some point. But we'll see. There's still a lot in the works for that. There's been some great resources. So the American College of Cardiology, American Heart Association, the American Podiatric Medical Association, so the podiatrists, the vascular people, Society of Vascular Surgery, all came together and they put together these guidelines for management of the lower extremity PAD, including things like wound care, revascularization options, and medical management. So those are some really good resources. There's also the International Working Group for the Diabetic Foot, and things like deep venous arterialization, that was in the 2024 ACC guidelines. The topical oxygen was in the International Working Group of the Diabetic Foot Guidelines. The ADA also puts out standard guidelines, but those two are the big ones to follow. And what are the key takeaways? So if we get to these patients earlier, there's a lot of technology that has evolved over the past 10 years that can save these patients' legs. So if you get to these patients early, they have a better chance of doing well, of saving their leg, of decreasing their mortality. If the vascular doctor says that nothing can be done, or they're not even willing to go, at least tell them to walk. Walking is for mild PAD is actually a really good treatment. So encourage walking after they've been revascularized, after they've had a wound. They need to walk every single day. It's really important in their care. And again, things have changed over the past year. There's been a lot of technology. The big thing is this is such a cost to the healthcare system that all these companies have really invested, and the government even has really invested into technology for the diabetic foot, for wound management, for PAD. And so we're seeing a real transition in the care. And multidisciplinary care, this is really big. Study after study has shown if these patients are in a multidisciplinary center or they're getting multidisciplinary care, they do better. And so, it might be harder. Rural medicine might be a little harder to do this. But at least if they're getting multiple opinions, one person, this is too much for one specialty, one person to handle. They need to have a group involved. Any questions, comments?
Who's still hungry? Question here?
I had two patients this last year that I would try to get them the deep venous arterialization, and I kept referring them to UC Davis and UCSF, and I couldn't get it for them. One of them has lost both his legs, and the other has lost one of his legs now. Amputation. Is there anything that I could have done to work him up better that would convince a specialist to do deep venous arterialization?
Yeah, do you want to?
Yeah, so the question is that she had a patient who had PAD, tried to refer for deep venous arterialization to a couple different institutions, was not successful with that, and subsequently had amputations of both legs. So the question is there something that she could have done preventatively to work up before getting to that point?
Yeah, so deep venous arterialization was approved, FDA approved about a year and a half ago, so still super new. So there's a lot of providers that aren't doing it at all. They do have, the company has a website that can like bring you to it. But I think because the technology is so new that it's hard to, get a provider that's willing to do it. Some of it is their anatomy. They have to have certain anatomy. They have to have a vein to go from. Their arteries and their legs have to be good. So not everybody's a candidate. But there are a lot of, there's only a few people in the country doing it now. And so, I think the only other, do they have like a wound care center or something at UC Davis where you sent? Okay,
They do.
yeah, because that's the only other thing of usually if you plug them into people that are really involved in the system, that's kind of the best that can be done, yeah.
Is there a particular infrapopliteal vessel? And how distal can you go with this arterialization?
So I don't do them, just, but it's usually from either the peroneal or the posterior tibial vessel. And it's a big, long stent, so it goes, you can kind of get it from the trifurcation up there, and it goes down and it flows through the plantar venous arch. So basically it's a vein that wasn't being used because there's no blood getting there anyway. Blood flows through it, it gets to the foot. And the other thing with anatomy is they have to have a plantar venous arch for the blood to flow through. So sometimes there's anatomical considerations for them to be a candidate.
Follow-up question. So how high up can you do the deep venous arterialization? Can you do it above the knee?
No, so it has to be below the knee. So yeah, specifically for below the knee, so it has to come off of one of the vessels right below the knee, yeah. But it's usually a long stent that kind of goes from below the knee to the ankle.
At what stage, how early would you recommend the foot x-ray?
So when patients come into my office, they're diabetic with a foot ulcer, we get an x-ray on everyone, ABIs and x-rays on everyone. And so an x-ray, it's easier for me because I have an x-ray machine in my office, so it's like every podiatrist usually does. And so that's a really easy initial screening. But if they have a foot ulcer, you should get an x-ray.
So
Also
a callus counts?
No. But a callus with a bruise underneath it, because usually that bruise is an ulcer. We don't want to waste resources.
Well, it's the future. We just need more surgeons to get involved in.
Yeah.
All right. Thank you very much.
Yeah.